Well, hello. My name is Dr. Shaw. I really do appreciate you taking the time to listen in and learn not only about sickle cell, but about the new guidelines. And in particular, what I'm hoping to pass on today is some of the content that the new guidelines have for you. We've made a big effort to try and make them very digestible. And really the most important part of all of this is to get those resources to primary care providers who then need to be able to know that we as specialists have their back. So again, I'm Dr. Shaw. I'm going to be giving the talk today, but I definitely have to recognize many others who have helped out. Dr. Tanabe, Paula Tanabe, is a key person in this effort. And I also wanted to make sure I recognize Dr. Tilson and Dr. Rothman, who also did quite a bit of contribution for this slide deck. I did want to mention very quickly here, the access to these slides are available online. And as I'll go through this presentation, you'll see that we have access to these guidelines and these resources online through an app. We'll give it to you in paper form. There's lots of ways to have access to all of these resources. So to start with, the objectives really are to first start with just laying the groundwork. Just put us back in perspective as to what it means to have sickle cell disease. Why are there complications? What are the main complications? And what are we supposed to do about them? The new guidelines, which were published, the 2014 guidelines, are an evidence-based as well as consensus expert opinion based guideline that really addresses a lot of different issues. And it's a really large packet, and we'll talk about them, but they're in particular specific parts that we want our providers and anyone who has the ability to care for patients with sickle cell to know about. And so those are health maintenance issues, acute problems, and then really dive into these tools that we've developed. The whole goal is this last line. We want to foster a collaboration, basically between the specialists and the primary care. We realize that a sickle cell patient has a lot of potential complications and has a lot that we should be considering when we care for them. So we really do need to try and work together to maximize and get the most benefit from these guidelines to take care of our patients. So to start with, let's talk numbers here. You know, if we thought about the total number of patients within the United States, it's about 100,000. That's actually an underestimation. But sickle cell disease is defined by having one gene from either mom or dad, who often don't even know they have sickle cell disease, or the trait, I should say. But they pass that gene on to their child, and when they are combined one S with almost any other hemoglobinopathy, that's sickle cell disease. And the classic description is sickle cell anemia, which is the more severe phenotype, and they're literally anemic, and that's why they're called sickle cell anemia patients. And that's the SS type or S beta 0 type. But in regards to how often do I see this in the community, I think the 1 in 375 African American births is a good number. The other way to think about it is about 1 in 600 or so patients in the United States. And so if you think of a large school system that has about 1 in 600, it's not uncommon that a teacher or a person coming across a child with sickle cell disease has no understanding of what sickle cell is. So there's a large amount of education that needs to come. We have many parents that come in with this new diagnosis that their child has sickle cell, and of course they're consulting Dr. Google to try and figure this out, and it's our job to give them the proper information and education about what sickle cell is and what it means to them. So the basic pathophysiology, and I promise not to get too scientific, even though it looks like it is. You know, the way I describe this to patients, families, and all our learners is that there's a small mutation, a small change in the amino acid that leads to a whole cascade of events. And if you think about it, amino acids are the building blocks for proteins. And so a protein in particular in sickle cell that is changed is the hemoglobin protein. And the hemoglobin holds oxygen. And when you have this little change in sickle cell, the problem is that once it delivers the oxygen, there's a charge. And your body doesn't like charges. It's just like a magnet. If you have a charge that's on the outside, magnets don't like having other magnets around them, because what happens is that they start stacking on themselves. So you see in the picture here that when they're in solution and it's oxygenated, the blood cells are nicely separated. But as soon as it delivers the oxygen, you have this stacking of the red blood cells, and that's what we call polymerization. That's the technical term for that. And the polymerization is where they stack and they stretch out the red blood cell. That gives you that classic sickled shape that you see. And the problem is not that it's just that shape, this rigid cell. It's that they're rigid and they're sticky. And not only are the sickle cells sticky, but the blood vessel wall becomes sticky because it gets damaged. The white blood cells are sticky. The platelets, which normally fight or stop bleeding, they're sticky. So all this sticky stuff causes blood to not go where they're supposed to go. And of course, then you have inflammation and swelling and this ongoing adhesion from that. So if I was to break down the different complications, they go back to the two main issues with sickle cell that patients have. And that's one is that the blood is breaking down, that's hemolysis, and when blood is breaking down, you have anemia, of course, because there's less blood. You have gallstones from the breakdown products. And then, of course, you have issues with blood not going where it needs to go because it just got stuck somewhere. So if blood's not going to the chest, that's called acute chest. And that's the number one cause of death now for patients with sickle cell disease. If blood's not going to the bones, that's a pain crisis, and that's the most common cause for hospitalizations for pain. And then, of course, if patients don't have blood going to their brain, that's a stroke, and that's a very significant complication, and something that we will talk about a little bit later. So really, there are a lot of complications, and I think that's what this slide highlights, that there are complications that basically affect almost every organ of the body, and therefore we need to be systematic and very regimented about following our patients closely to make sure we don't miss any of these complications. So this is a screenshot of what the new guidelines, the front page looks like that was put together and published. And it's a really big packet, and it's very detailed. Like I said, it's evidence-based, so it gives you summary recommendations, but then it goes into very good detail of why they're making these recommendations. And I'll say this because I do reference this packet quite a bit. We recognize that this is such a big packet that if you really want to go to sleep well at night, this is a packet to review, but we know you need something more digestible on an everyday basis. And so that was the task that was put to us as sickle cell specialists, as providers, academic centers around the state, and state key providers that wanted to make sure we had something that was easy to look at and easy to access. So that's what we did. And we got all these key people in a room. We met several times throughout the year and really give a lot of credit to CCNC for that. But the tools that we keyed in on were, again, knowing that we have all these complications with sickle cell disease, we wanted to make sure that the health maintenance was well outlined. What are the things that we need to make sure primary care doctors are checking for and asking about? And then what are specific complications that patients have that we need to make sure that if they come to their office and have this complication, how do I help them walk through that process? If they come in with a fever, what should they be thinking about? If they come in with respiratory symptoms, knowing that the number one cause of death is acute chest, what should they be doing, and what's the algorithm to walk them through that process? And we put together all of this into tip sheets and clinical pearls. So let's start with health maintenance. And so with health maintenance, a couple things to remember are, first, there are a lot of other comorbidities that coexist with sickle cell. Asthma is worse in sickle cell than having asthma alone, and so we do need to make sure we're asking about shortness of breath, wheezing, and if there is asthma, we need to be very aggressive about making sure that that's well controlled, because that is, of course, a significant contributor to issues with acute chest if that becomes a problem. In regards to obstructive sleep apnea, again, not often asked about, but how well are they sleeping at night? Are they snoring? What do their tonsils look like? We need to be asking these things as they get older, because again, if they're not breathing well at night, because they have obstruction of the breathing at night, obstructive sleep apnea, then they're not getting oxygen. And oxygen is the big issue here. We need to make sure that they're getting enough oxygen because that's going to cause problems with sickling. And finally, dental caries. I cannot tell you how many times we need to make sure we remind our patients to see the dentist at least twice a year, because once they get an infection in their teeth and in their jaw, it's really hard and has a high rate of that infection getting worse for our patients. For retinopathy, we do have screenings in place. Of course, if it's a very young toddler, they're not going to complain, but you do want to make sure that the parents are asked, are they having any issues with seeing things and playing with their toys that you might recognize that may make us want to do an extra test. We do basic screening after that, and of course a dilated exam starting at age 10. And finally, we have listed here renal disease, and that's just because there's a high rate of spilling protein in the urine, and we want to make sure we catch that early so that we don't miss a potential cause for the kidneys to have issues. Other problems within health maintenance are surrounding the fact that stroke is a big issue. We need to make sure that we pick up on the risk for stroke and pick up the potential that they've had a stroke, a silent infarct. And so the first thing here we have listed is that to have an annual transcranial Doppler. That's basically doing an ultrasound of the blood flow that goes to the brain. As the blood goes to the brain, it's basically a pipe. And as that pipe becomes tortuous and has little kinks in them, the blood flow has to get faster to get past that kink and to get through that tortuous blood vessel. So we monitor that with an ultrasound every year. And if that blood flow velocity gets really high, they're at high risk for stroke. And we need to do something to intervene. And that something basically is transfusions or exchange transfusions to try and bring down the number of sickled cells, because that's been shown to make a big difference in reducing the risk of stroke. In regards to neurocognitive symptoms, again, it's really something that you have to have in the back of your mind, that these patients, even if they don't have an overt stroke, that they come in with weakness or tingling, but they may come in and just start to have these complaints that they're not doing well in school. They have more headaches than usual, things that don't seem to make sense. And in those situations, you may want to make sure you consider that maybe they've had a silent stroke, and there's a high rate of silent strokes in these patients as well. And the next line here we have is we no longer routinely do pulmonary hypertension screening. It's all based on clinical symptoms. So if they're short of breath, just like considering asthma, if they're an adolescent, a young adult, or if they've had a history of increasing shortness of breath in those age ranges, you need to make sure you just consider that as being a potential cause as well. And then you would make sure you do the workup, which includes EKGs, echoes, x-rays, and so forth. And finally, priapism is something, again, not mentioned often in the primary care setting, but in the specialist clinics, we always make sure we ask. About 40% of males with sickle cell disease have a history of priapism, which is a painful erection over 2 hours. And so we need to make sure that our males with sickle cell are aware of this, as well as our primary care doctors asking if that's a complication, because that needs to be addressed. So infection used to be the number one cause of death. It's no longer that. Like I said, it's acute chest. But the reason it's not the number one cause of death is because, number one, we have mandatory newborn screening. So every baby born now we know has sickle cell, and we get them on antibiotics. And the antibiotics that we have listed here, the dosages are not as important, but the fact that they need to be on antibiotics as soon as we realize they have sickle cell, and continue it until usually about the age 5, and to make sure that they've finished their immunizations at the 5-year mark. There are situations that they may continue it longer if they've had bacteria in their bloodstream, or if they've had their spleen removed. But for the most part, getting their antibiotics is the first part of this, and the last part of this is to make sure they get their immunizations. And the immunizations continue through adulthood. And so there are definitely recommendations. They do change every so often by the CDC, but we definitely want to make sure that there are, at this point, 2 types of pneumonia shots that they should be getting, 2 types of meningitis shots that they should be getting, and all the other immunization shots as well that they should get as a child. In regards to hydroxyurea, I'll pause for just a moment here to say this is a big deal. Hydroxyurea is pretty much the only approved drug. And I know I used to say it was the only approved drug. There is a second approved drug now, but it's L-glutamine, and we haven't really found our place as to where that fits in with everything and what we're going to use that with our patients. But hydroxyurea, we have years of experience to say this is not only an approved drug, but it has a lot of data to show that it does good. And so the problem comes about is from that first line. It was originally used as an anti-cancer medication. So of course, if someone Googles it, they're like, oh, this is chemotherapy. There's hesitation by patients, family, even other medical providers that, I don't want to be managing or recommending a medication that could be a chemotherapy type agent. But it's an extremely different situation. We're using it at a lower dose for sure. We're not causing the amount of damage to the bone marrow that could be had with hydroxyurea. And we're giving it in a low dose to try and trick the bone marrow to make more baby blood. So it increases fetal hemoglobin. And like we said, oxygen is our friend. And fetal hemoglobin holds on to oxygen. Just like a baby in the womb is not breathing, it needs to hold on to the oxygen. But once the baby's born, it doesn't need that fetal hemoglobin, but we're going to trick it to say it does. And that's what the hydroxyurea comes in. So the hydroxyurea increases the fetal hemoglobin, prevents sickling by holding onto the oxygen, and finally lets blood cells live longer, lets the red blood cells live longer in the bloodstream. But all the data continues to grow, and some of the things that we can see very clear is that there's less painful crisis, there's less acute chest, so there's less significant complications, less transfusions. And that last part there, that's what I always make sure that I say at least once in a conversation about hydroxyurea. It reduces mortality. We have more than one study now that has shown that it reduces mortality. So you can say you can have less pain, you may have less organ dysfunction, you may have less complications that might cause you severe problems. But the moment you say, but you can live longer on this medication, you at least pique their attention to hear a little bit more. And so I definitely want to emphasize that from the data. So this is the slide I show our patients. I mean, again, this is your blood on hydroxyurea. This is your blood not on hydroxyurea. Any questions? And it's very clear. You can see that the hydroxyurea effect on the right here causes very big, juicy blood cells. Whereas on the left, you don't see very many blood cells at all, and what you do see is a lot of sickled cells. And so you can see where the big difference is between the two slides. Now we've expanded the use of hydroxyurea. It used to be just an adult medication that was based on the initial MSH trial, the multi-center sickle cell hydroxyurea trial done quite a while ago. But the difference is now we've done studies in kids. And in kids 9 months and older, this baby hug trial, which we were a part of here at Duke, it was very clear that we didn't wait for children to have problems. We put them on hydroxyurea from the beginning. And when we put them on hydroxyurea, they had less issues. And again, the data continues to come out to show how much benefit hydroxyurea gives our children even before they have problems. Now, for the adult study, because these are recommendations based on evidence, we're going back to those initial trials where we waited for our adult patients to have problems before they were put on. It actually doesn't really make sense that I can put a child on it before they have issues, but an adult I have to wait for issues. So for the most part, most providers really realize that we don't need to wait. Now, a good question came up in one of the talks that I've given, which was, does that cause issues with prior authorization? The fact that I'm prescribing this to an adult before they have issues, and that's not been the case. The rationale for prior authorization is completely separate and comes down to insurance coverage and wanting them just to understand why that they need to be on hydroxyurea in general. So I do want to make sure that we understand that hydroxyurea is a big medication we need to be pushing for our population. Now the last line here on this slide is to key in on just one specific point, which is that the vast majority of patients are SS and S beta 0. Those are the sickle cell anemia patients, just about 2/3 of our patients. But other patients like hemoglobin SC or S beta plus, there are more and more studies, retrospective and from experience, that we're using hydroxyurea in those populations as well. So in general, if they're having problems, you should be considering hydroxyurea. If they're not having problems, especially when their SS and S beta is 0 because they're anemic, you need to be considering hydroxyurea. So here's the algorithm. Again, I've done a lot of talking, but we recognize that primary care doctors and most providers are extremely busy, and they just want to know what they need to do when they see their patient, when they're on hydroxyurea or not. And so the first question is for a pediatric patient. This is a pediatric algorithm for hydroxyurea. First question is, are you on hydroxyurea? And if you're not, why not? Because there, like I said, a lot of good evidence that they should be on hydroxyurea. And we have access on this algorithm to click on to go to handouts to give them about hydroxyurea, to go to the newest evidence-based guidelines. And if they are on hydroxyurea, the next big point we really need to make sure to emphasize is, are they taking it? And are they taking it like they're supposed to? We really have more and more evidence to show that patients are not taking it like we want them to. They're not filling it, and if they do fill it, they're not taking it. And so we really need to make sure we not only understand that it works by taking it every single day, but also that when they take it appropriately, that they do better. And so we have to ask. We have to ask, are they taking it? And if they're missing any more than one dose in a week, then we need to make sure we understand how can I maybe improve that. You know, there's calendars, there's schedules, there's apps, there's all kinds of ways to help that compliance and adherence to taking their medications. So the next thing as a primary care doctor, if they're taking the medication and they're not missing any doses, but what kind of dose are you on? Has it been a stable dose? Are you in the right dose range? And we recognize that we do not expect primary care doctors to be titrating these medications. This is something that we want them to be aware is going on, but we don't expect them to take control. But we do want to have them understand there are blood counts that need to be monitored, and so if they're not on a stable dose and they're concerned or have any type of question, they can draw some blood work. And if the blood work shows that it's not in the sweet range that we have listed here, they may need to hold it or at least talk to a sickle cell specialist. The next slide is the adult form of this. The adult algorithm is essentially the same. Are they on hydroxyurea? Are they on a consistent dose? But the last part, the very end of this, is to just show, is that patient having any complications with acute leg ulcers? So leg ulcers are extremely rare as a complication caused by hydroxyurea. A little bit less common, actually a little bit more common in patients who have sickle cell and not on hydroxyurea. But the issue here is if you have a leg ulcer, even if it was a diabetic leg ulcer or a wound injury, you need white blood cells to help the healing process. And so hydroxyurea, like I said, calms the bone marrow down, and it's what we call is myelosuppressive. And that's a good thing with hydroxyurea. Hydroxyurea decreasing white blood cells, decreasing platelets, and increasing the hemoglobin because they live longer, because they hold on to oxygen. Those are all three good things because white blood cells, like I said, are sticky, platelets are sticky. But when you're trying to heal, you need those white blood cells. And so in that specific situation, you may need to hold it. Again, the algorithm walks you through this whole process. In regards to dosing, we don't expect primary care providers or non-specialists to take the the helm of this, the reins, I should say. But what we have here is the dosages that we usually start with. For children, 20 milligrams per kilogram per day. For adults, 15 milligrams per kilogram per day. These are both once daily, just to kind of clarify. Sometimes that comes up as a question. And then we want to titrate them. That's really key. If you don't titrate them, then you're putting them on a dose, but you're not maximizing the benefit. And to maximize the benefit is to get them up high enough dose that I'm getting their bone marrow to be a little bit calmer than it usually is. And the maximum tolerated dose has those blood count guidelines to kind of guide you as to where I hope they are. And again, the specialist is going to do this. The specialist is going to initiate it. I don't even recommend initiating it while they're in the hospital. I think this is a conversation that the specialist should have. But for sure, a primary care doctor can have the conversation to say, this is something, and I think this is something important. And I think that that's a good point to be had, because every patient needs to recognize that hydroxyurea is a good option for them. And so the titration is really similar to an anticonvulsant, anti-seizure type medication, where the neurologist is doing all the titrating, but we want the primary care doctor to know about it and know it's being titrated, and even draw a level if there's some concern. It would be the same type of analogy. In regards to reproductive counseling, because hydroxyurea is a teratogen, you really need to know about the fact that if you're on hydroxyurea, you need to hold it. The first step is, if there's family planning, what's the partner's genotype? So again, just like the parents that come into your office and they didn't even know they had trait, a patient who has sickle cell disease and is family planning, they have to hold the hydroxyurea, but they also need to consider what is their partner's genotype to make sure they understand the risk of their child having sickle cell disease. And then if you're on hydroxyurea, you need to make sure you're considering a long-acting reversible contraceptive, which is progesterone only, and that has to be key. Estrogen, as a hormone, increases your risk for blood clots, and that's for any female, independent of having sickle cell. But sickle cell has a higher risk of clots in itself. So if you add sickle cell and estrogen together, it puts you at a much higher risk for clots, and so we definitely want to recommend a non-estrogen product for contraception. And the risk for hydroxyurea to the baby continues even while breastfeeding, so we want to make sure that while they're breastfeeding, they continue to hold that hydroxyurea. So this looks like, and it is, a busy slide, but it really is, if you want to have one page that is a reference point for all the health maintenance stuff that we talked about, you can see for the adults, this is the first slide here, which is adults, that we've separated into pain, history, physical labs, and so on. And so that the doctor can basically key in on parts of this that they think are an issue for their patient. So for example, if in the history, things that you need to be asking about are hydroxyurea, if they've gotten transfusions, how their vision's doing, and so on. Of course, pain being the big issue with our patients, and making sure that we have a good plan, you need to ask how often are you having pain? What's the frequency or severity of this pain? And there's a little reference to the fact that there's a pain algorithm, which we'll talk about in just a moment. And if they have priapism, do they know what priapism is? And are they able to make sure that they let you know as soon as possible about the... So I think this is a good reference point, and as I'll mention at the end, there are a couple places that our providers and provider teams have access to this, but this is just one, kind of put it together and have different parts of it that a provider can key in on as needed. There's also a pediatric version of this. The pediatric version is separated, understanding that most pediatric patients come in for their well child check, so we've separated it by age, and so just similar to having a 12-month well child check or a 2-year well child check, we want you to kind of, again, key in on specific things at those ages so that you know that you're addressing topics that we feel as sickle cell specialists and providers to make sure that you talk about while you have those patients in the office. So what are the acute problems? And really some of these are chronic problems as well. But again, there are a lot in the guidelines, but there are these 5 issues that if they come to your office and have these problems, we want to help you know the algorithm of how to help you know what to do next. So if you have a fever, if you have respiratory issues, so again with the number one problem we're trying to avoid being acute chest, if they're really just anemic and tired, of course, if stroke being the bad outcome that we want to avoid, you need to make sure you're asking about it. And of course, finally, pain. That pain is, I think, the big talking point, and we'll make sure we have some recommendations to discuss there. So in regards to fever, the first bullet is just to say you need to have a prompt evaluation for children. And if they're less than 1 year of age, it's really the only way they can show that they're having a problem, and you need to get blood work and immediately give antibiotics. We went ahead and gave you recommendations for when they need to be hospitalized. So if they come to your office and they're less than 1 year, it's an automatic admission. Just like if they had a really high fever, over 103.1, or if they have a history of bacterial infection. And I also have here, and I think this was well agreed upon, if you are unsure about the follow-up, if this is a patient you haven't seen for a couple years, they don't ever come to their appointments, they haven't seen the sickle cell specialist, and now they're in your office with a fever, then you really need to consider having them admitted for at least observation to follow up on that blood culture and get the antibiotics into that patient so that you're not having them lost and finding out that they really did have a bad infection in their blood. So this is the algorithm. Again, for adults, if they look ill, that's the big problem. If they have a fever and they don't look ill, then we feel fine about following them as an outpatient. But for patients that look ill or have extremely high fevers or have a source, especially if they have something that makes you worry about acute chest, this basically walks through the type of antibiotics to consider, type of blood work to be done, and if you need to have this patient go to the emergency room. We have the same thing for pediatrics. The only revision here again is, as I said, if they're less than 1, it's an automatic admission. You really need to make sure you work quickly to get antibiotics in them, get the blood work drawn, but you need to have them admitted and watched. If they're over 1 year, you then again want to make sure that how do they look? Do they look well? Do you have a source? Can I follow up this patient as an outpatient? But otherwise, if there's anything that's concerning, you may want to have them admitted, and it walks you through that process as well. I do have red flags listed in the lower left corner, and those are really just a review of what we have said before. In regards to respiratory symptoms, the number 1 cause of death. I cannot say that enough. So the reason that we make the diagnosis very broad now, which is basically is that you have any infiltrate, anything you see on an x-ray that looks like a pneumonia, combined with almost any other symptom or signs. If you have shortness of breath, chest pain, fever, tachypnea, breathing fast, any of those symptoms or signs with that x-ray finding, even recognizing that the x-ray finding may lag behind, we want to make sure we're not missing acute chest. And a lot of times usually it's in the lower lobes, but it's a combination of issues going on, and that's why it's so important to find out, and it can go bad quickly. It's because there's infection kind of overlaying with sicklings, there's all this blood clumping in that area, there's a lot of times evidence of fat emboli, and even atelectasis, which is collapse of the lungs. And so the combination of all these things going on can lead to a very bad outcome and very quickly. So we want to make sure we pick up on this quickly. For a patient coming to the office with respiratory symptoms, the first question is just, are they in distress? If they're in distress, send them to the emergency room. Get them to triage the patient and get them some treatment quickly. But if they look well, get the pulse ox to show that they're oxygenating nicely. But the next step is, are they wheezing? Because if they're wheezing and they have asthma, as I said in the beginning, asthma is a different animal within sickle cell disease. Patients with asthma and sickle cell do worse than just patients with asthma alone. And so you need to give them a bronchodilator or give them something to try and address that. But if they're not wheezing, then go through the pathway and just make sure you're not missing something else and continue to reassess and make sure you're not missing something like acute chest. If they're anemic, it's a little bit more simple, but what we're trying to highlight here is that patients can be anemic for different reasons. And so you want to make sure you're not missing something. So if they have worsening anemia, that's the first key word, worsening anemia. So you kind of need to know their baseline to know if it's worse. And so the baseline can vary. And for example, a type SS patient who has sickle cell disease has a hemoglobin in the 6 to 7 range, let's say. A type SC patient has a hemoglobin at baseline in the 10-11 range, for example. So they both have sickle cell disease but have very different baselines. And so you need to make sure that is understood. And the same thing goes if a patient is on hydroxyurea, non-hydroxyurea. The patients on hydroxyurea usually have a higher hemoglobin. But if they're coming in, they're fatigued, they're tired, they have more jaundice, their eyes are more yellow because there's more destruction going on. You need to make sure there's not another thing that you need to treat. Do they have a pneumonia? Do they have a large spleen or a liver? So you need to examine them. And you want to make sure you just get some labs to document how far this worsening anemia might be for this patient. If it's less than 2 grams from their baseline, or if it's less than 6, you need to figure out what the next step is. And for sure, sending them to the emergency room, talking to the sickle cell provider, depending on how they're clinically doing, is definitely warranted. We do have added here to look for antibodies. There's a lot of overuse of transfusions. We don't transfuse for pain crisis, and the rationale is that the more you transfuse, there's risk of iron overload and there's risk of antibodies developing. It's just like if you get blood transfused to you, your body eventually says, this ain't my blood. And so when your body says this isn't your blood, it starts attacking it. And that's the antibodies that are being developed. As I said, neurologic complications are a big deal. So if a patient comes in with an acute deficit, you need to worry about the risk of acute stroke, and you immediately need to get them to the ER and get a scan. Even before you get blood work or anything else, get that CT scan, get that workup going to try and address if they're having a stroke. But even vague symptoms, like I said earlier, headaches can be a very vague, sinister symptom, and we want to make sure we're not missing something. Moya moya is really just a Japanese term for puff of smoke, and it's really what you see on an MRI. When you do a picture of this, an MRI, when you do a picture of the brain, you see this collateral vessels that are in the back of the brain, and it really just looks like a puff of smoke. And so you want to make sure you're looking for that, because that's a high risk of bleeding and having a stroke if you have these really small, fragile blood vessels in the back. And so you definitely want to make sure you refer to the specialist for that workup. But silent infarcts are a big deal as well. So even if you don't see an acute stroke where a patient's coming in with weakness in one arm or leg, or they're having tingling or slurred speech, they can have on scans evidence of having silent infarcts. And there's a recent trial done by Dr. DeBon up at Vanderbilt who found that a good number of patients, a quarter of patients with type SS, will have strokes. And so you need to make sure that even if they don't have an overt sign of stroke, if they just are having problems in school, or if they're just not able to think clearly anymore, and it's a definite change, you need to make sure, is there something that I'm missing? And it's a big thing to find, because if I do find a problem on an MRI, I need to consider, is this a patient I need to put on chronic transfusions? Do I need to make sure that they're at higher risk for further strokes? We need to address those issues. And so we need to refer them to neurology, neuropsych, the specialist, and so on. We do have IEPs listed here. There are a lot of patients who have silent infarcts or not who do have cognitive issues, and we need to give them the support they need. Again, the next algorithm here is again just to get them to address those 3 main points I just made. If they have cognitive decline, make sure you do a full exam and history. If they have headaches, remember you don't want to miss moya moya. And if they're having an acute issue, you need to work fast. You need to get them into an ER so they can get exchange transfusions. And exchange transfusions where you're just taking out all their sickle cell and putting in non-sickle cell so that you can try and reduce the number of sickle cells that are floating around. And finally, the last section here for the guidelines is pain. And this is the big talking point with sickle cell disease. So I want to make sure that we have a good discussion so you understand what we're trying to do to help providers take care of patients like sickle cell who have a lot of pain issues. And so to start with, if a patient comes in pain, we want to just tease out, is this an acute crisis or is this a chronic pain issue? They had this for a good period of time, over 3 months or longer. And so if it's acute pain crisis, the first thing you again want to make sure is, am I missing anything else? If they're in pain, are they having pain crisis because of priapism? Are they having pain because they have acute chest or a spleen issue? There are a lot of other things that can cause acute pain, and if that's not the situation, then do they have a good pain plan? If they do have a cause of that pain, like a spleen or acute chest, then get them to the ER and make sure that they work it up. The key term here is pain plan. Do I have a plan? You want to think about the plan. The patient should know the plan. The provider should know the plan, and it should be well documented so that we're all on the same page. And many times the pain plan will for sure, of course, include keeping warm, fluids, and ibuprofen as an anti-inflammatory. But anything beyond that should be well spelled out and really dictated well, so that when they try it, we know that they've done what we have recommended, and if it doesn't work, then we can then refer them to the ER. In regards to chronic pain, again, are we missing something? There are situations that we can maybe do something about. If they have avascular necrosis, where they have breakdown of the bones in either their shoulders or hips, then maybe we need to get them to the orthopedic surgeon to address that. If they have leg ulcers, like I said, we need to make sure that we're monitoring that closely to try and help that heal. So there are situations in chronic pain that can make pain worse. But if it is a patient with chronic pain, and even with acute on chronic pain, we need to be very careful, especially with the opioid concentration of efforts now nationally. We need to make sure we're checking the database. We need to make sure we look at what providers are giving medications to our patients, and we need to make sure there's a pain agreement in place. And so one provider on that pain agreement is the one that's taking ownership of the fact that they're prescribing these medications to that patient. And then if the next part of this is aligning ourselves with those national efforts and being safe about what we're doing. So we want to not only not only assess a number. So we know that patients with chronic pain may have an 8 out of 10 at baseline. So it's hard to assess that I've made any progress with that. And so the way I ask this is, how active are they? Are they able to get to work? Are they able to get to school? And if they're able to do that, then we know we're doing well. And of course, there are other ways to assess functional status, quality of life, and doing depression screens. But a simple thing is just to ask, were you able to do what you normally do through the week? Or are things worse than they usually are? So, we do have pain as the number one issue in sickle cell disease. It's a number one cause for hospitalization. It's a number one comorbid issue within sickle cell disease. But some patients don't have issues at all, and some patients have pain all the time. But at some point, they're going to have pain. So we definitely want to have a pain action plan, a pain plan in place. There are things that precipitate it: illness, being sick, just even having a common cold, stress, even just having a grandmother die can definitely cause a pain crisis, because stress in of itself can cause sickle cell pain crisis. And finally, dehydration and even not breathing well. If you're dehydrated, you're concentrating those sickled cells and causing more problems. And pain in sickle cell usually is in the same place. It's usually in the extremities, but usually most patients will say, yeah, it's the arm I usually have pain in. And then when it goes somewhere else, that's when you actually kind of want to pique your attention a little bit more, because maybe something else is going on. But you always want to ask where the pain is, and it can be extremely severe, and recognize that an abdominal pain from sickle cell crisis can even be mistaken for a surgical condition, and be something that really warrants a really careful consideration. Now we want to, like I said, based on the algorithm, assess all the other complications, but really most of our pain plan is palliative. So you want them to be warm, well hydrated, follow the pain plan you've put in place, and if it doesn't work, get them to the emergency room. In regards to chronic pain, we're starting to understand that chronic pain is extremely difficult to manage, but we want to make sure that we are logistically systematic about how we address it. And so there are, like I said, major causes for acute pain, avascular necrosis, and so on. But a lot of our patients become tolerant. So the more pain medications that a patient's on, the more their body says, been there, done that. And so we need to recognize as providers that it's not that they're addicted to the pain medications, but it's that they're tolerant. And to make sure that we're avoiding things like diversion, which is that, again, they're not addicted, but they're taking the medications but diverting it somewhere else. That's why we need to make sure that we have a very systematic way of looking at the database, making sure one provider is giving the prescriptions, making sure that we have a pain specialist or a sickle cell specialist involved all the way through. So I'm ending with the last couple slides here. And I'm ending by saying we're here to help you and help the providers have access to these guidelines. So we made this app. It's on Apple, and no disrespect to any Android users out there, but the Android app is in process, so it's being made. But the Apple app is free to download right now. And so if you go to SCD Toolbox on the App Store, it should pre-populate the password 1234, but that gives you almost full access to the whole app. And when I say almost full access, it gives you access to the guidelines, basically the big slide that we had for adults and pediatrics for all the health maintenance things that we want to have remembered. We have the algorithms built in there, and the only part that's not fully accessible is, and if you email me, I'll give you full access, and that's just so you can register with me. But the full access just allows you to then email me or text me or even call me and ask me about a patient. Now, I do have Dr. Iffy on this as well, and my goal is that it's not just myself or Dr. Iffy, that we'll have specialists around the state. And it really comes down to making sure that the doctors understand and any provider understands that we're here to help you through any complication or issue. And so we have these flyers that we want to be distributed to all of our practices that care for patients with sickle cell disease. And it really just, again, on the left here, just highlights the fact that it isn't an app form, and it's some facts about sickle cell disease. But it's all there. I mean, all of it's there, and we're going to continue to give more information as they potentially should change or we feel needs to be refined. So what we're asking is on the right. What we're asking our QI specialists are to make sure that, with this report being run, we know where these identified practices are in your network that have sickle cell disease. And we want you to print that list of patients for each of these practices and highlight the patients that haven't been seen in the last year. Like I said, we need to co-manage these patients. The specialist and the primary care providers both need to work together to maximize our care. And so if you highlight those patients that haven't been seen, we want you to then take this list, as well as the flyer and these algorithms in paper form, and give it to the practice. And then, of course, when you give it to them, you can say, I know these are a bunch of papers, but we have it not only in paper form, but we have an app. You have access to Dr. Shaw and you and Dr. Iffy. We have a website which you can access, so you can just log on if you want to. And we want you to reach out to these practices in person and by letter and phone calls. And we want you to go out to these practices and make sure that they know about this. When you go in person and do this, have them understand that they need to go to the patients that haven't been seen and tell them, when can I get you back into our office? And they can do that, again, by mailing something to them or calling them. But we want you to follow up with that process. So again, to summarize what our train the trainer model is that myself and Dr. Tanabe are training you as QI leads and as people who will then train the next level of specialists and through this type of session. And then once you train your QI specialist, then you'll go through this spreadsheet and tell us who's been trained. And then when they go out to their assigned practices, then we'll have some documentation. And when you go to the specialist, we want you to talk to at least one clinician. So I'll revise and be very clear about that, what I have said before. Have each QI specialist go directly to the practice and talk to a clinician. You can follow up by phone, you can follow up by mail, but that face-to-face really means a lot. And again, as I said, if you have that list of patients in their practice, you highlight the ones that haven't been seen in a year, and say, we hope that you can reach out to these patients and schedule a visit. And these are the resources you have with this flyer for the app, these paper algorithms, and you have websites to get onto, but really try and see if they can get a hold of those patients. And then finally, number 5 just says, we want you to reach back out to them. Go back out if you need to, but call them. Make sure that they've been able to reach those patients that haven't been seen recently. So there is a timeline. We wanted to just at least put some firm timelines so we know that we've put this out there in a, again, systematic way. And we want all the QI specialists in your network to be trained in at least 30 days from your training. And then the QI lead will then take the spreadsheet back to Kern or Emily 30 days after your training. And really, the whole point here is to just track the engagement we're getting. And so we want to know what patients are able to be re-engaged into those practices. Now, we have offered very clearly myself and Dr. Tanabe to be there to do in-person review. If a practice says, we would like Dr. Shah or Dr. Tanabe to give additional guidance, we will give an in-person review. We want to be there. So if that does come up, take down the information, get it to Kern or Emily, and we will make time for that. But I really just want to end here by saying, you can email Kern, Emily, Dr. Tanabe, but I'm available all the time. I cannot end but on a really important story, and that is that the app went live on the App Store several weeks ago now. But 2 days after it went up on the App Store, and we had kind of advertised that it went up on the App Store, but Dr. Matthews, who's an internist out in the Greensboro area, called me after hours. I had just finished my son's soccer game, and I picked up the phone. I actually didn't know it was Dr. Matthews, and she was freaking out because a patient of hers was having a stroke, and she didn't know what to do. She kind of knew what to do, but she was obviously warranted to be concerned. And so I walked her through that process. We, made sure we got that patient over to Duke. But I was just very happy to hear that we now have a tool to quickly get a provider the help they need. And the stroke being the extreme situation. But there are always questions about a specialty population like sickle cell. And we want to make sure that our patients get the best care. And this, I think, these tools and this app and the ability to reach out to specialists are an extremely important way to do this. So I just want to give one last slide as I'm ending this discussion to say forward thinking, and that is that there is what we call an echo clinic or an echo model coming from the Carolinas Health System in Duke. And we're really excited to be part of this as well. Echo just is really kind of like a telemedicine idea. You can even get CME by attending these virtual lessons and sessions. But basically, you're talking about patient cases with people around the state in a virtual way and learning from each other. And so the Echo model should hopefully be coming soon as well. So we have a lot of good efforts within the state. I'm excited as I give these type of talks all around the country to say that North Carolina is definitely a leader in what we do. And so we recognize that we have great people helping us give the good care that we hope to give. And we're only striving to do better. So thank you very much again for taking the time to listen to this discussion. Email me. If you download the app, you can text me or send me information if you need to, but just ask the questions if you need to. Appreciate your time. Thank you very much.